I'm going to talk to you about my topic, which is Methotrexate, a guide for professional use. Even though I'm not exactly a professional, I'm going to give it a try. So, as we all already know, Methotrexate is a widely known drug and used in our daily practice for various diseases. So, I've tried to bring together some general aspects that I thought would be useful for day-to-day management and things we might not know, or tips. So, this is roughly the outline I'm going to follow. And getting into the topic regarding dosage, as we already know, it's a single weekly dose. From 7.5 to 25 milligrams, it's recommended to start with 7.5 milligrams per week, and depending on how it's tolerated, gradually increase by 2.5 milligrams weekly. Additionally, it's important for the doctor to specify the day of administration on the prescription to prevent patients, especially elderly patients, from making mistakes when taking the treatment and potentially getting intoxicated. Another point I also found interesting to mention, to bring up related to the composition, is that oral methotrexate tablets contain lactose, so it's also a factor to keep in mind for people who are lactose intolerant like me, as it could be another reason why the medication is poorly tolerated. Additionally, it's also important to consider that before starting folic acid supplementation, it's advisable to check vitamin B12 levels, since treatment with folate supplements could mask the symptoms of a vitamin B12 deficiency. Regarding renal function, as we all already know, the dosage needs to be adjusted accordingly. In cases of liver failure, great caution is also required, especially in alcoholic patients, and it would be contraindicated if bilirubin levels are above 5. Another thing I also found interesting is that caution is needed in patients with a third space of distribution, meaning patients who have ascites or pleural effusions, because the half-life could be prolonged up to 4 times the normal duration. Therefore, it might be necessary to reduce the dose. In fact, there are authors who say that theoretically, pleural effusions and ascites should be drained before starting treatment with methotrexate, partly to avoid this. Side effects, if you look at the prescribing information, there are a billion of them, but I've brought up some of the most common and important ones. Nausea and vomiting, as we already know. Some tricks to try to avoid them would be to split the dose into 2 or 3 intakes on the same day, take methotrexate right before going to bed and just let whatever happens happen overnight, or the third trick would be to combine it with primperan. So we also have to keep in mind that the subcutaneous method of administration, even if you switch to the subcutaneous route, it doesn't prevent the onset of nausea since it's a systemic effect. Other side effects include hair loss, sun-induced ulcers, elevated transaminases. As we already know, it's not necessary to reduce the dose unless the levels exceed at least 3 times the upper limit of normal. Other side effects include cirrhosis, cytopenias, and regarding cancer, it's important to note that it does not increase the risk of cancer. Another side effect that is somewhat more significant is pneumonitis, which can occur at any treatment dose, even at low doses, and at any point during the treatment. It is an acute reaction caused by a hypersensitivity mechanism. It should be suspected when a patient develops a cough or shortness of breath that cannot be explained by an infection or another cause. It is advisable, of course, to have a chest X-ray taken before starting treatment in order to compare any changes that may occur. And methotrexate should not be reintroduced once the condition has resolved, since it is a mechanism of hypersensitivity and it could happen again. The treatment involves glucocorticoids at high doses and respiratory support measures if needed, and in principle it usually progresses well. However, according to a case series, mortality can reach between 10% and 18%. Another thing to keep in mind is that it may have a slight to moderate impact on the ability to drive or operate machinery, so patients should be slightly cautioned, especially those in certain professions. Then here's another tip as well. Something we can use in monitoring to know if our patients are deceiving us and not taking the treatment would be follow-up blood counts, specifically checking the mean corpuscular volume. And if it's not above 90, it could be because the patient is not an indicator that the patient is not taking the treatment. Drug interactions as well. If you look at the prescribing information, there are a lot, but I've brought here the ones that seemed most important to me because they're medications we use quite frequently. So the first one is what we already know. Any drug that reduces glomerular filtration can increase methotrexate levels. So we need to be careful, especially with NSAIDs and salicylates due to how frequently they are used. Intestinal absorption could be reduced by antibiotics. Then we need to be cautious. Also with drugs like metamizole, which has a myelotoxic effect, because when combined with methotrexate, it could cause severe myelotoxicity. Additionally, the prescribing information states that excessive consumption of alcoholic beverages should be avoided, with caffeine or theophylline, that is coffee or black tea, since the effectiveness of methotrexate can be affected due to interaction with adenosine receptors. And finally, omeprazole prolongs the renal elimination of methotrexate, so it could cause interactions, and this occurs less frequently with pantoprazole than with omeprazole. Regarding pregnancy, as we already know, it is contraindicated because it is highly teratogenic. Women should use reliable contraceptive methods for up to 6 months after discontinuing methotrexate. It is also contraindicated during breastfeeding because it is excreted in breast milk. And regarding fertility, it decreases fertility because it affects spermatogenesis and oogenesis, but these effects are reversible once the treatment is discontinued. In male contraception, it has been observed in animal studies that it is genotoxic. Therefore, it cannot be completely ruled out that it may have a genotoxic effect on sperm. Although the available clinical data, while limited, have not shown an increase in malformations, a certain level of caution is still advised. It is also recommended that men use reliable contraceptive methods for at least 3 months after discontinuing methotrexate. And here, well, to wrap up, some methotrexate administration recommendations from the American College of Rheumatology 2021 have been brought in, which are just 4. The first recommendation states that oral methotrexate is conditionally recommended over the subcutaneous form when starting treatment, and this is justified somewhat by the convenience of the oral route. The second recommendation advises starting treatment with at least 15 milligrams of methotrexate rather than lower doses. The third recommendation refers to a patient who does not tolerate oral methotrexate. It is worth trying either splitting the dose into multiple intakes throughout the same day or switching to the subcutaneous route, or increasing folinic acid supplementation. With the aim, basically, it's advisable to try this before switching to another conventional DMARD. And the final recommendation is for patients who have not achieved the treatment goal with methotrexate. Again, it is worth trying the subcutaneous route before switching to another conventional DMARD.